The first major category of tests evaluates gastric acidity. Stomach acid plays an essential role in initiating protein digestion, stimulating pancreatic enzymes and bile release, absorbing minerals like iron and calcium, and protecting against pathogens. Both low stomach acid, hypochlorhydria, and absent acid, achlorhydria, can significantly impair downstream digestion and absorption. Clinically, we also can see excessive acid, and a lot of patients will often assume that their acid reflux symptoms or symptoms of indigestion are associated with too much acid, but that is not often the case. Some causes for low stomach acid or decreased stomach acid production include age-related decline, which is extremely common, pernicious anemia or atrophic gastritis, reflecting an autoimmune or just a destruction of parietal cells, can lead to both low intrinsic factor and low acid. Systemic disease like chronic renal failure, adrenal insufficiency, and autoimmune diseases like RA and vitiligo can also impair HCl production. And low hydrochloric acid can present very similarly to high hydrochloric acid with bloating, early satiety, malabsorption, or even chronic nutrient deficiencies, specifically B12 and iron. In contrast, excessive acid production, when present, is usually associated with pathology. Zollinger-Ellison syndrome and gastrin-secreting tumors can be classic causes from a clinical perspective. Peptic and duodenal ulcers can be associated with increased acidic output. Another cause is hyperfunction of the antral G cells, leading to gastroesophageal reflux disease, and even a history of small intestine resection can be related due to altered feedback regulation of gastrin and acid secretion. Traditional gastric analysis requires placement of a nasogastral tube. We then aspirate fasting stomach contents and evaluate volume, pH, presence of blood or bile, and basal acid output. Then we administer a stimulant, often histamine or pentagastrin, and measure the maximal acidic output. While this test gives a direct measurement, it is invasive and requires procedural proficiency and emergency preparedness, especially regarding gastric stimulants and possible adverse reactions. The main takeaway here is that ND Scope does allow this test in Oregon specifically with additional procedural training. The patient must be fasting and must discontinue acid blocking medications, alcohol, and caffeine prior to the procedure. This also shows it emphasizes our clinician responsibility when using gastric stimulants. You need advanced training and preparedness to manage adverse effects. In practice, we rarely use this test today because newer, more non-invasive methods can provide similar information for less patient harm. Looking at the normal reference values for this test, however, a normal stomach sample is clear without food, blood, or bile. pH should be between 1.5 and 3.5. Basal acid output, or BAO, without stimulation should be between 0 to 5 milliequivalents per hour. And maximal output should be increased to about 10 to 20 milliequivalents per hour. Knowing these numbers can help you interpret whether a patient's dysfunction is related to too little or too much hydrochloric acid production. The gastro test or the gastric string test provides a more non-invasive alternative to gastric analysis. The patient swallows a gelatin capsule that's attached to a long pH-sensitive string, and the capsule dissolves in the stomach, exposing the string to gastric acid. The string is then removed, and the color changes compared to a pH chart. This test estimates gastric acidity without the need for a nasogastric tube placement, making it much more comfortable and accessible. Once the string is in the stomach for about 10 minutes, we gently pull it back out and lay it on white paper. We then apply a pH developer stick to the portion that was exposed to the stomach contents and compare the color to a standardized pH chart. A normal pH should be under 3. In hypochlorhydria, the pH may be closer to neutral, but it can still fall into the quote-unquote normal range, meaning the patient might have low acid even if this first test looks normal. With achlorhydria, there will be a clearly elevated pH because the acid is absent. You can also consider a bicarbonate challenge. If the initial string test shows a pH above 3, we do not need further provocation because this suggests achlorhydria. But if the initial pH is normal and we still suspect low acid, we challenge the system by giving a sodium bicarbonate. In a healthy stomach, bicarb temporarily neutralizes acid, but parietal cells quickly respond by producing more. In hypochlorhydria, the stomach fails to reacidify. So this test reveals whether the stomach has functional capacity to produce acid. The gastric test has, or the gastro test or gastrocapsule test, has been compared to gastric intubation and demonstrates a 93% correlation. This makes it a relatively reliable and much less invasive method for assessing gastric acidity. It's relatively inexpensive, easy for patients, and avoids the discomfort and clinical risk of nasogastric tube testing. It's why in clinical practice the string test is much more frequently used than gastric analysis by tube placement. The Heidelberg test is another non-invasive option, and it's considered one of the most accurate methods for assessing gastric pH in real time. The patient swallows a pH-sensitive radio transmitter capsule, and an external receiver records continuous pH data. Unlike the string test, this allows us to monitor pH dynamically over time and during challenges. However, this method tends to be more expensive and requires specialized monitoring equipment. The results are interpreted kind of as shown on this screen. So a fasting pH above 3 suggests achlorhydria. The sodium bicarbonate challenge is used similarly as with the string test, and bicarbonate will temporarily neutralize acid. And then you can assess how long it takes for the stomach to reacidify since we're watching in real time. Normally, the stomach should drop back into an acidic range within 12 to 33 minutes. And the test can also measure small intestinal pH, giving additional information on downstream digestive function. Some advantages of the Heidelberg test are that it directly measures pH, it measures reacidification time, and it can track pH as the capsule travels into the small intestine. But the drawback is cost and availability. Many clinics do not have the access or the required equipment to perform this test. And because of this, even though it's really informative, its use in general practice is pretty limited. When we come back, we'll look at some absorption tests.